Hello and good evening, everyone. It's great to be back here once again with all of you, and welcome to my advances and welcome to our webinar tonight. It's wonderful to be here. As I've mentioned, I always am happy to be here, and I know that you have probably plenty of questions, and we are going to discuss an interesting topic tonight, which is low ovarian reserve. And as you know, our series of events is mostly about success rates, success stories, of course. Sorry, IVF cases. And we are here again, and we will have another expert in the field, fertility specialist, Dr. María Calomarde. Sorry. It's great to have you here. This is your first webinar with my IVF. So welcome on board. I hope that you are feeling good and are ready to share some of your knowledge, some of your past success stories as well. So welcome, Dr. Maria. How are you feeling tonight?
Thank you very much for the presentation. I'm really good, thank you. And good evening to everyone. And welcome to this webinar about low ovarian reserve. And if you want, we're going to start. That's right, Caroline?
Yes, of course. Let me just remind everyone that we will start with the presentation on the topic. So, as I've mentioned, Dr. Maria will tell you a bit about low ovarian reserve, what can be done with it. But of course, afterwards, you will have time for your questions. So, as always, remember you can put those in the chat section, and Dr. Maria will answer them for you right here live, of course. So, don't hesitate. Anything that's on your mind, I'm sure that she will be able to help you out. Of course, remember that if there will be lots and lots of questions, which I'm sure you will have, there is always a possibility for you to get in touch directly with Dr. Maria and her team at IVF-Spain, located in Madrid. And I'm sure the team will be able to help you out with some more details. And well, I guess let's get going with this topic. I'm really looking forward to this. So I guess we can start with the presentation. Yes, Dr. Maria?
Okay, perfect.
Excellent. Thank you so much, Dita.
So we start, okay? I am Dr. María Calomarde. Nice to meet you. I've been working in IVF-Spain since 2016, so since 6 years ago. And we're going to talk about low ovarian reserve, okay? What we're going to talk about low ovarian reserve, and I'm going to, okay, perfect. What we can see here in this graphic is how live birth percentages decrease since overall 39 years old, okay? And which are the indicators of a good ovarian reserve? The most important one, how we can see, is the mother's age, okay? And we can study that ovarian reserve with, let me see, 1 second, please, sorry. So we can study that ovarian reserve with an ultrasound, okay? An ultrasound, which is really useful because in consultation and with that one, what we are going to see is the count of the antral follicle count, okay, and with the result of the AMH also in a blood test. Here we can see how the level of that AMH decreases with the age, and we can consider an AMH level of 1, for example, limit. So here we can see since 25 years old, an AMH normal is 5.4, till more than 40 years old, we can see that it's lower than 1, for example. And the follicle number is going also to become really low since 40 years old. Here in that graphic, we can see how it's more or less 35, when overall 40 years old is going to decrease importantly. But we can't study the quality of the oocytes with that indicators, okay? This graphic represents the relationship between maternal age and the aneuploid rate. In other words, the quality of the embryo. That is going to depend on the quality of the oocytes and the sperm tube, okay? It can be observed how until the age of 35, the rate of aneuploid embryo is established at 50%. After this age, the percentage starts to decrease, showing a drastic decrease after the 40s. Okay, young women younger than 35, I mean, have a good ovarian reserve normally, which means that the capacity of the ovary to provide egg cells. Okay, hence at this age there is a high probability of finding a healthy embryo without any issue. Okay. However, up to 35 years old, the ovarian reserve starts decreasing as the ovarian quality does. It is more common having troubles when trying to get pregnant with a higher miscarriage risk, of course. Finally, we can see that at the age of 43, okay, here more or less, it is almost impossible getting a natural pregnancy with women's own eggs with an IVF. Okay. So let's clarify what we mean with the term of genetical issue. An aneuploid embryo has an abnormal number of chromosomes in a cell, being 46, the usual number. Okay. For instance, if there is an alteration in the chromosome, for example, 21, the diagnostic will be Down syndrome. If it happens in the chromosome, this one, 18, the diagnosis will be Edwards syndrome. And when this alteration occurs in the chromosome 13, it will be known as a Pateau syndrome. These three cases are known as trisomies alterations, which do not hamper the pregnancy and the birth of a child, for example. And it exists other alteration, of course, in embryos that in most cases will end as miscarriage or as a negative pregnancy test. So let's talk about different cases that we have normally, daily in the consultation. Here we have a case with a partner. The woman had 35 years old, the first day of first consultation, with an IMH of 0.8, okay, and antral follicle count of in total 5, okay. And he had 36 years old and teratospermy after the sperm study. Well, she had no pregnancies before, and they tried to conceive since 2 years ago without previous IVF cycles, okay. Well, after all the studies and everything, we start with the first IVF cycle. Of course, we discard the artificial insemination because the rate of succeed was really low, so it has no sense. So we start with IVF cycle with a short protocol with 5 days of omitting, okay, and the rest of pergoveris during 10 days, okay, 150. And the result was 3 follicles in development, and finally in the egg retrieval we find no mature eggs. So that means that we have no embryo transfer in the first IVF cycle. In the second one, we try again with a short protocol with gonal, in that case menopause 2. Finally, we have 3 follicles in the development, similar, but in that case there's 1 mature, and we fertilize that one with the sample sperm, and we have 1 embryo that doesn't arrive to the state of blastocyst. So we have again no embryo transfer. We tried with a third one, okay, because she was really young and she wanted to do everything as soon as possible, okay. And we tried with another cycle with a short protocol, but with a lower doses, but similar, okay. Yes, 1 follicle was development, and then we get 1 oocyte mature, and we have no fertilization of that one, no embryo transfer again. So by the moment we have no embryos in state of blastocyst. Well, in that moment, okay, we were discussing in the consultation what to do, or if it's the moment to change to egg donation, or they wanted to continue trying, okay. And it's going to depend on psychological situation of that patient and also economically situation of that patient. They wanted to try again with another one. And I offer that kind of protocol that is called mild stimulation protocol, and it's really low doses of drugs, okay? And it was Olmephen. It's just one pill every day, and just menopause with alternating days since the 4th day of stimulation. So fourth day more or less period, because we start with the first day of period, okay? So it's really low. And then with that one, we have the same development, 3 follicles, that's similar to the rest of cycle that we did. Then in the egg retrieval, we were really happy, really glad, because we had 3 mature, 2 of them fertilized, and then finally we had 1 embryo with a middle quality, but 1 blastocyst. This was the first time for them. So we did a first transfer, and we have the positive pregnancy test, a healthy baby girl. So they were really happy. Then we have the second case. In that one, we have an older older partner. We had a woman of 39 years old with an AMH similar 0.7. Okay, but we had she were older. Okay, the antral follicle count was 6. Okay, then he were at 41 years old. He had a normal sample of sperm and 2 previous children. Okay. Then she had an ectopic pregnancy with left salpingectomy before, and then they tried to conceive since 1 year and a half, more or less, and they have also no previous IVF cycles. Okay? Well, we talk about try again with try first time with her own eggs, but continue with the own eggs. But always PGTA because of the age, okay? Overall because of the age. And then we try with the short protocol with antagonist, with pergoberries, okay, at normal doses. So we have in the ultrasound 6 follicles in the development. In the egg retrieval, we got 5 oocytes mature. 4 of them were well fertilized, and then in total in the state of blastocyst we had 2 embryos. Okay, finally, so 2 blastocysts. We did the biopsy. Well, the biologist did the biopsy of the blastocyst the same day for the PGTA, and then we froze all the embryos. And then after 3 weeks that we have the results, we had 1 of them were euploid, that means normal. Because we have just 1, so to have more information about the case, we try to know more about that window implantation, and we did the ERMA, and it was receptive at P6. P plus 6, that means that 6 days of progesterone, okay? And after all of that, we did the embryo transfer, the freeze and the transfer, and we had a positive pregnancy test and a healthy baby body. Well, perfect. I have finished my presentation, my short presentation, because I want you to know all your answers, your questions, sorry. I will try to answer all of them. I don't know if Caroline is going to be connected now.
Yes, of course. I'm right here with you, of course. Dr. Maria, thank you so much for your presentation, for providing this interesting case indeed, and of course for explaining all the details. And yes, now it's definitely your favorite part. So remember, I know that you probably have been listening to the presentation, so there are not so many questions, but I'm sure that you have some. So now it is your time. Go ahead, type those in, and Dr. Maria will help you out. There is first question from Emma, so I guess we can start with this one, and let's have a look at the question. Sorry, just give me a second. It's right here. So, what is your opinion, experience about human growth hormone for oocyte quantity or quality?
Well, I have listened about that hormone in fertility treatments, but we have never tried with that one because there's no conclusions in the studies. Okay, so normally we don't use that hormone to improve the quality or the quantity. Okay, because what we are trying to practice, okay, it's with the growth factors, okay, but not with that hormone, because by the moment we have no treatments to improve the quality or to improve the quantity. Okay, yes, the quantity is going to depend on an overall only on the age, also on another diseases, for example, polycystic syndrome or endometriosis, that is going to decrease that quantity and also the quality. But not, sorry, that's not, I don't know about the human growth hormone in that case.
Okay, thank you, Emma, for your first question. Of course, thank you for your answer to this. So, this is something that is still being investigated, I understand, and it's just
Okay.
not enough data to confirm that it definitely works, right? All right, thank you so much. And let's have a look at the next question from Jose. Do you use estrogen priming?
What do you mean with estrogen priming? If you mean, I think that you mean that just to prepare the endometrium, or I don't really understand that question.
Mm-hmm.
Maybe,
Okay, Jose, if you can clarify, just add some things so we can
yeah, because
okay,
yes, of course,
show
we
it.
use estrogen, but not for the ovarian reserve, not to improve the ovarian reserve or to improve the quality of the oocytes, just to prepare the endometrium.
Okay. So someone is typing. I will.
Well, maybe that question, maybe I think that maybe the question is if we use estrogen before the stimulation of the ovaries.
Okay, sorry. There is this follow up to prepare follicular growth synchronization.
Okay. To prepare for exactly.
Okay.
That's what I think. So yes, normally we use that, but it's just to prepare that synchronization of the follicles, and also to just in terms of organization here in the clinic. Okay. Or, for example, if that patient prefer to delay a little bit the egg retrieval, for example, in that case, yes, but not to improve the ovarian reserve or to improve the quality. Okay.
Okay, understood. So it is used just for different than one. Okay. All right. Thank you. And let's have a look. Can you have too low AMH to get help with own eggs?
Mm, can you have Tilo to get help with own eggs? Well, one thing is the AMH, okay, and another thing is the quality of the eggs. I have, for example, a patient. She was 36, 37 years old, okay, and with an AMH of 0.09, so really low. The count of follicles, for example, was one, and one in each, so two in total, okay. But she never tried with an IVF. She never tried at home, just 1 month or so. It's not representative. And I advised her to continue trying because yes, so she tried to conceive just 1 month. So I gave her, I think, yeah, it was just omething. Okay, she had one follicle and a half, and she gets pregnant the second month trying with that AMH. So no, the AMH is not, it's the total of information we have about this patient. For example, it's not the same that AMH with that age, 35, for example, or 37, than, for example, with 42. That's really common to have a really low reserve, really low AMH. So no, we have not a limit of AMH.
All right, great. Thank you so much, Karen, for your question. So thank you for encouraging and your. I mean, definitely, it's good news to hear from you, Maria. Thank you so much indeed for clarification. And let's have a look. Okay, more questions are coming in, as you can see. And let me go to the next one from Deborah. How long do you freeze embryos? If I were to stay in Spain to do cryopreserve sperm, do you inseminate?
How long we freeze embryos? Well, we have no limit, okay? But one thing that is important, because if you want to be here in Spain to do a cryopreserved sperm, okay? So I mean, I think that you were talking about an IVF with sperm donor sperm, okay? In that case, you can come here, but we can't give you a solution to your fertility preservation, okay? What we can do is, or cryopreserve your oocytes, for example, for your fertility, or if you want, we can do an IVF with sperm of donor, okay? And we can freeze the embryos, but we have to try with that embryo. So if you, for example, get pregnant, or for you it's not possible to get pregnant now, and you want to try in 2 months, for example, we can, and the embryos can be frozen years. Okay. I don't know if it's that's the.
Okay, sure. Thank you so much, Deborah. If there's anything you would like to add, you know what to do, and we will be able to go back. Yes, okay, all is good. And there was a thank you from Deborah here.
Clear.
Thank you so much. Okay, next question. Does higher BMI affect the quality of eggs?
Yes. What we can see in all the studies about the body mass index is that affects to the quality of the eggs. Overall, if you have polycystic ovarian syndrome, in that case, for example, what we have seen is that if you lose a little bit of your weight, at least 5%, for example, the quality of the eggs is going to improve. Okay, but if you have obesity, for example, yeah, it's really well. We can see that the quality of the eggs is lower. Okay, and also normally here in our clinic, we try to do the treatment. Yes, if you have a body mass index lower or more or less, not more than 35. Okay, if you have more, for example, we advise you to lose weight till 45 of BMA, because the risk of in the pregnancy with that obesity is really high. Okay.
Thank you so much for the clarification again, and let's have a look. Is it common for someone to have relatively high MH for age and respond poorly to stimulation? I am 40 and my MH is 21.5 picomoles. I got 9x on my first cycle and 6x on my second one. Same dosage, 300 IU of medication on both cycles.
Yeah. Well, you have not for me, it's not a cruel stimulation. You mean that you have just 9x, but it's a really, really good number for your age. That dose is 300, it's high. Okay, I don't know your body mass index, because it's going to depend also on that. But the doses for me, it's correct. With your age, normally the AMH, normally we use another units. We have to divide that with 7. So I mean, this is more or less 3 for me. So it's a normal AMH. So for your age is really high, and the number of eggs is quite good. So in that case, what I would advise you, for example, in my clinic, is to accumulate, to do an embryo banking. Okay, I don't know if you have a partner or not, but doesn't matter. What I advise you is just to do an PGTA. So what we advise you is just to accumulate the embryos, to do an embryo banking, for example, to get advantage of one PGTA, that is the biopsy of the embryos, just to discard the ones that would be abnormal. Because the problem in your case, I think that is not your ovarian reserve because of your age, because you do have a good ovarian reserve, but maybe the quality is not so good because of your age. That's why I think that the best thing is to do the PGTA, and the stimulation is really good. 300 is high.
Again, thank you so much indeed for the clarification. And there's a thank you for your answer from Fabiana as well. Okay, great. Thank you so much. And Deborah has added one more question. So when do you use growth hormone therapy is this with PRP? I'm trying to use my own eggs.
No, PRP is that one that I told you about the growth, but it's growth factors. It's not growth hormone. It's different. Growth hormone is one hormone that we produce, and growth factors that are in the blood that we have to get out with one technique, and in the laboratory. And normally they put that PRP inside the ovaries or inside also the endometrium when we have a problem with the measure, the endometrial lining, the measure of the endometrial lining. We can use two dots too, but we have no conclusion yet. It's not the same.
All right, again, thanks so much for the clarification to this question as well. Okay, next one is definitely a longer question. Okay, so let's have a look at this. This is lots of details, but I'm sure we can manage. I'm 40 with reduced ovarian reserve, AMH 0.51, normal FSH, normal estradiol, and had undergone 2 long protocol stimulation cycles in Swiss fertility centers. During first cycle, ovulation occurred before harvesting, and of initially 11 follicles, only 3 oocytes remained. 2 could be fertilized and 1 developed to blastocyst stage. We did PGTA. Unfortunately, the blastocyst had too many mosaics. Next cycle was the same protocol, but with additional ibuprofen. That time ovaries weren't synchronized, so at harvesting 5 oocytes were retrieved from only 1 ovary, 3 fertilized, 2 blastocysts were sent to PGTA. We got 1 good quality euploid blastocyst. Unfortunately, implantation failed. Would you recommend trying another IVF cycle with same protocol, switching to another protocol, or considering donor egg IVF? Are there other factors to be considered like uterus lining, immunological factors? Would you recommend some testing for that? I already had hysteroscopy before starting with cycles.
Well, you have a really common case, okay? But yes, you have a lot of information. I think that the best thing is just to get an appointment with us if you want. We have a patient meeting this weekend, not the next weekend, okay, if you want. But what I can see is that you have tried 2 times with PGTA, okay? With both of them were 2 long protocol stimulation cycles. Oh, well, okay. Maybe in your case you can do another protocol that it's short with agonist, okay, different. Yeah, we can try with another one because we have seen that one is not good for you, but we can't know if it's going to be similar or we're going to improve, okay, because we can know if your response is because of the protocol or because of the quality of the eggs, okay, because of the age is normal, that is the quality is going to be poor. So yeah, we can try to change, we can try to improve obviously. And what I advise to you is just to accumulate with that embryo banking more embryos, at least with your age 5-6 embryos, with several cycles. And then with that one, we're going to do just 1 PGTA and to try to find 1 normal. Well, you have already tried with 1 normal and you have implantation failure, but we can't know if it's normal or not, because with 1 embryo, more or less, you have 50-60% normal embryo, 50-60% of succeed. So in that case, it's a risk that you have to take, okay, or try again with your own eggs. It's going to be hard because you have to do several cycles, you have to try. Obviously, donor egg IVF is going to be easier and quicker, maybe, okay, because normally the rate of success is higher than comparing with the own eggs, and also normally in the clinic we have guarantees. So yeah, of course, before you try overall, if you have one embryo normal too, before new embryo transfer, I will do test. Okay, for example, yeah, you say immunological factor. Yeah, normally we can do one blood test that is called, it's a study of coagulation and immunology. Okay, and also what we can do is just a biopsy of the endometrium to check the window implantation, because I think that you have no pregnancy. You have no pregnancies before. Well, an hysteroscopy with a biopsy also can help. So we can do a lot of things. Yeah, of course.
All right. Thank you so much, Stephanie, for your question with lots of details. And thank you, Dr. Maria, for your help with that. And yes, as you've mentioned, it's possible to get an appointment and get some even some more details. I'm sure Dr. Maria needs even more details from this, right, to make to be able to help you out even more. But there's a thank you from Stephanie for you right here. Okay, let's have a look. Tani has another question. I'm 49 and have only 1 year to try to get pregnant. My AMH is 0.2. I don't have menstruations. Is it still possible somehow to try stimulating my own eggs, or should I go straight for egg donor?
You have to go to egg donor. Yeah, we have no pregnancy since 44 years old. It's really, really difficult. So with your age, it's not important the AMAs in that case, because we know that the quality of the eggs are going to be really low. So in your case, you have to try with egg donation. Yeah.
All right. Thank you for the clarification here as well. Okay. And what do you recommend to patients to improve their egg quality?
Well, the egg quality can be improved, for example, with vitamin. So it's going to depend on each case, okay? But for example, in ovarian syndrome, we can try to give, for example, metformin. If we have a resistance of insulin higher, or we have an overweight, we can lose weight, for example. Obviously, health life. So you have to practice sport. You have to not. It's not necessarily a diet. Yes, with real fooding diet. Okay, I think that is really useful. And also, yeah, we are studying that PRP factor that we now have no conclusions. And but with the age, for example, if you have a low quality of the eggs because of the age, we can't do nothing. Also with endometriosis, it's really difficult to improve the quality because it's a disease that is it's really common, and it's difficult to treat. And also with the surgery, for example, we can't improve in that case. Okay, so in that case that the quality of the eggs is really low, or we can try, yes, with young people. Okay, I think that the limit is 38. We can try with that mild stimulation. We have really good results. Okay, or if not, I think that the best thing is that to change the egg.
All right. Again, thank you so much for helping us with this as well. Thank you for the question, of course, as well. Okay, more questions are coming in, and of course, there is a thank you from the patient for you. Okay, Deborah has added, how long does it take to see eggs forming after PRP?
Normally, what we are studying, okay, more or less what we have is 1 to 3 months. Okay, we can know if it's going to be, we are going to see the differences in more time, but more or less 1 to 3 months. Okay, to know
right.
if
Up to 3 months, you just need to wait, more or less, right? Okay, thank you. Thank you, Deborah, also again for the question. And one more from Michaela. My first IVF 12 eggs collected resulted in 4 perfect blastocysts. My second IVF 11 months later with same protocol collected 10 eggs, resulted in 3 morulas that arrested on day 6. I gained quite a lot of weight before second IVF. Do you think if I lose weight, I can improve my egg quality again? I'm 35 with unknown AMH.
Yes, I think so. Maybe you have a normal AMH because you have a normal count of eggs. Okay, so the AMH is not going to help us to give us information, more information. Yeah, your weight. If you have more weight, for example, between if you have gained that weight between one and another one, you can see the difference. Okay, so obviously, if you lose that overweight that you have gained, yeah, you will see the difference. Maybe it's just a chance, okay, because not all the stimulation are going to be the same, are going to be similar. You can have a stimulation and it's not so good in comparison with another one. Yeah, it can change. The stress, for example, can influence. But of course, I think that situation of your overweight has an influence. Yes, of course.
All right. Again, thank you so much for that. Another advice, of course, right here. Okay, for now at least, it might be our final question. So let me remind everyone that if you have more, go ahead, type those in. And Emma has added one more question. Is might IVF suitable for someone with low ovarian reserve?
Yes, of course. That one normally, what I try always is with a normal doses, okay? First, because what we have to try just to get as many oocytes as possible in all of that case of infertility. But that mild stimulation, normally when we, like the first case that we have seen, when we try with normal doses and we have not a good response and we have not a lot of eggs, so in that case, or not a good quality of the eggs, in that case, always I advise to try with that one because my experience, okay, it's really good with that protocol. Overall, with low than 55, 35 years old, but also with 37, 38. Yeah, I think it's a really good protocol.
Okay, perfect. Thank you for the clarification and your question, Emma, as well. Okay, Karen has added one more question in the meantime. So I'm 43, have low AMH, haven't tried IVF yet. Do you recommend IVF for me or not?
Well, yes, it's going to depend if you have not tried with your own eggs with an IVF. It's going to depend on you. If you are prepared psychologically to do several cycles, probably at least 3, to accumulate the embryos, to analyze all the embryos. Yes, in that case, because it's going to take more than 6 months, okay, 5, 6 months at least. And if you want to fight for your own eggs and to try without guarantees, because we can't guarantee you that you might imagine that you're in your cycles, you're trying to accumulate 5, 6 embryos. We have patients with a lot of embryos and with your age more or less, without normal embryos. Okay, we can have that case. So you have to risk. If you want, yes, it's possible, and it's not crazy. It's possible, but obviously the rates of succeed is going to be higher with egg donation. But normally, always, if you have never tried, normally always I advise you to try at least once. Okay, to see how your ovary responds and how many embryos you have with one stimulation, and which is the quality of the eggs. Okay.
Thank you for yet another advice, of course, and Carmen for your help, for your question. Okay, let's have a look. Okay, Karen has said thanks as well for this. And next question. So where does someone go to find embryos in preservation and at what cost? In the States or in Spain, which may cost less? I can travel. Okay.
I think that you mean embryos in preservation, you mean embryoduction. I think that you mean
I
embryo.
believe so, yeah. Just clarify this for us, Deborah, right? If you mean embryo adoption.
Because I think
Yes.
you mean, yes,
Mhm.
that's embryo reduction. Yeah. So the cost of that embryo reduction, I think that it's different between different clinics. Okay, so the best thing is just to you to ask to different clinics if you want to compare the prices. Okay, I remind you that we have a patient meeting with me in 2 weekends. If you want, we can talk about that. But and the cost is going to be given for you, yes, for the commercial people, and without problems. Here in Spain, it's legal, and there's no problem. What we can do is just we can give you. Obviously, it's anonymous in Spain, and also we can give you the characteristics of the donors because it's like an adoption of a baby. Okay, but with an embryo. They are frozen. They are here waiting for someone who adopts them, and yes, we can give you the same race as you. For example, yes, this is we're going to give you the same race, but not the same characteristics as you. Okay.
And thank you so much. I believe that explains it. Okay. All right. Okay, Deborah, I will just put a link right in the chat section where there is a possibility for you to get in touch with Dr. Maria and her team at IVF-Spain Madrid, and you will be able to simply use that. And I'm sure the team will be happy to help you out with more details on costs, etc. I know that they are always doing a great job. We've had many webinars with IVF Spain from different locations, so I'm sure they will be happy to help you out. This is the link. I just sent it to you. And there is a contact button there. And if you use it, all the questions are sent to the team right there. Okay, I hope that helps. And I believe that that was our final question. But as I mentioned, if you have any more questions, you can always get in touch with IVF Spain. I'm sure they will help you out. And as Dr. Maria already mentioned, there is also a live session with her, right, this weekend. So you can join, you can ask more questions. I'm sure it's going to be interesting for you. So thank you everyone for joining us tonight, for your amazing questions, as always, many details as well. And Dr. Maria, thank you so much for joining us, for being a part of our IVF webinar sessions. And it's great to have you here with us. And I do hope that you found it interesting for you as well. And
My pleasure. Thank you very much.
thank you so much. And is there anything else you would like to add before we finish?
No, yes, that ovarian reserve is something else that is really common because nowadays the society normally we have the babies later and later, so that's really common. And don't worry, if you have more questions, you can ask me by email or in patient meeting, wherever. Okay, I will help you.
Wonderful. Thank you so much indeed, everyone. And I do believe that it's been very useful for you. Remember, we will be back here tomorrow at 7 p.m. UK time. There is another topic we will discuss, this time genetics and, of course, success stories. So go ahead, register if you haven't already. I'm sure that you will find this also interesting. And Dr. Maria, it's been great to have you with us tonight, and I do hope that we will have some more opportunities to cooperate. Have a lovely evening, everyone. Enjoy it. And of course, if you need anything, get in touch with us or with IVF Spain, and I'm sure that we can handle your case as well. This is always possible, and we need to stay positive, always positive, right? So thank you so much indeed. You know that you will be able to find this webinar on myivfenses.com, but also on our YouTube channel. And if you subscribe, you will be notified that the video has been uploaded. It will be available tomorrow for sure. So thanks a lot. Have a lovely evening and take
Lovely.
care.
Bye
See
bye.
you. Bye
See
bye.
you.